Vascular disorders of placenta are of many types. So, first of all, we will be discussing about the vascular supply of the placenta, and there is also a whole lecture in which the placenta or the anatomy of placenta was discussed, and the vascular supply of placenta was discussed in very deeply. So you can review that lecture if you want to know about the vascular supply of placenta in more detail. So there are different vessels, the arteries, veins that are supplying the placenta that comes from the maternal side. Then the blood is poured into the intervillous spaces inside the placenta, and then the nutrients are then absorbed from the structures known as villi that are the part of the placental vascular system into the venous and arterial system of the fetus, and that is via the umbilical cord. So the whole process continues. But if there are certain disorders that are present at the level of placenta, where the whole interaction of the maternal and fetal circulation was taking place, and the nutrients were basically exchanged and absorbed, the oxygen and all the important compounds were absorbed from there, that is the placenta, into the fetus. So if those vessels are somehow disrupted, there can be any disease of vascular system, all the diseases like formation of certain type of thrombi, embolism, uh, disruption of placenta, or bleeding or formation of hematoma in the placenta. All of these will result in the same thing, that is the distress of the fetus because of the dysphagia that will take place as a result of the whole event. So in this lecture we will be discussing about those vascular disorders that takes place at the level of placenta, their pathogenesis, their pathology, their outcomes, and finally their clinical signs and symptoms and their clinical importance. So the first topic that we will be discussing in our lecture is the fetal thrombotic vasculopathy. So, first of all, as the word is suggesting, that fetal thrombotic vasculopathy, the presence of a thrombi. Thrombus is basically a blood clot that has adhered itself with an artery or a vein, and it was basically formed over there. There was some damage to the artery or vein, and over there fibrin and other materials which were, with their first purpose was to recover that area of the vessel, but as a result the adherence of the platelets took place over there, and as a result a thrombi was formed. Now this thrombi, or they can be more than one, can be formed anywhere in the circulation from the placenta till the umbilical cord. So anywhere these thrombi can be present, and as they're present inside a vessel, so we are calling the whole process the vasculopathy. So there are certain risk factors that can lead to the process, and then we have certain outcomes of the whole disease. So the risk factors are, the first one is the villitis. Villous or villi are the structures that absorbs the nutrients from the intervillous space and pour them into the vasculature or the circulatory system that reaches the fetus. So whenever there is inflammation of villi because of any infection or because of any unknown cause or non-infectious cause, it is known as villitis. So because of villitis, there will be the presence of eosinophils, the macrophages, and all the inflammatory cytokines. And because of the inflammatory process going on over there, the absorption of those nutrients will be disrupted and will be affected. So the first risk factor for fetal thrombotic vasculopathy is the villitis. The second one is the disorders of coagulation. Of course, whenever there are disorders of coagulation and there is activation or abnormal activation of coagulation cascades in the body, they will affect the placenta, and as a result of that abnormal coagulation, thrombus formation and emboli formation can take place at the level of placenta. The third and the last risk factor is the hypercoagulable syndromes. So the enzymes and the compounds that are responsible for the aggregation of the platelets over a specific area inside the vessel, when they are increased, they will cause hypercoagulable syndromes, and in various areas of the body small thrombi are usually formed as a result of the disease, and hence as the placenta is also the body part at that time, so that is also affected, and a different thrombi can also be seen in its structure. So now we will be looking at the diagram that will show us the presence of thrombi inside a placenta. Okay, now this is a placenta. These are the villi. This is the intervillous space. This is the decidua basalis. Decidua basalis is basically responsible for differentiating between, or basically making a boundary between, the placenta and the uterine wall, so they are not connected directly to each other. Between them, a decidual layer is present, and what if that layer is not present? That is also a hallmark and disease, and we will be discussing that condition in this lecture later on. So these areas over here, these reddish areas are basically showing us the presence of thrombi inside the placenta. This enlarged area over here, if you can appreciate it, this is showing us presence of a thrombi inside a small vessel, hence occluding it completely. So this area is now not absorbing any type of nutrient from this intervillous space. Now, what are the outcomes of the fetal thrombotic vasculopathy? The first one is the stillbirth. That means that the child was dead when he or she was born. Then we have neonatal death. And finally, we have intrauterine growth restriction. That is because when the insufficient amount of nutrients are absorbed from the intervillous spaces into the villi and then into the they reach the fetus. So because of that insufficient or unfavorable external environment for the fetus, intrauterine growth restriction is usually seen. And the last complication is the neurological injury. Neurological injury will occur because the growing brain is very sensitive, and when it is not getting the appropriate amount of oxygen and nutrients, it will injure itself. The necrosis and other processes will start over there. So because of the less nutrients or a less amount of oxygen that is being taken up by the villi, will lead to the decreased amount of oxygen inside the fetal body. That will lead to asphyxia, and asphyxia then will lead to neurological injury. So in this slide, we will be discussing about the microscopic view of the villi, that how they appear under the microscope when we are talking about fetal thrombotic vasculopathy. So this slide is basically showing us the villi, the vessels of the villi that has been become thrombotic and fibrotic over time because of the chronic thrombotic process that was taking place over a period of time. So these vessels were supposed to be open and have a lumen so that the blood can flow through it and nutrients can exchange themselves, but instead it is filled with fibrin materials and compounds, and because of the fibrosis process that has taken place inside of them. Now the second picture is basically showing us a cross section of the vessels of the umbilical cord, and right over here we can see a large thrombus that is occluding the vessels inside the umbilical cord. So as we have talked before, that thrombi can be present inside the placenta or in the umbilical cord. They can be anywhere. So this is a large thrombi that is affecting, and that is reducing the cross-sectional area of the vessel from where the blood was supposed to flow into the fetal body and provide it with the appropriate amount of nutrients and proper gaseous exchange. Okay, now the second condition that we will be discussing is the hemorrhagic endovasculopathy. It is also known as hemorrhagic endovasculitis. There are certain risk factors or there are certain associated conditions with it, like irreversible injury to the endothelial cells. The hemorrhagic endovasculopathy is associated with irreversible injury to the endothelial cells. The endothelial cells inside the placenta, here we are talking about, will be damaged irreversibly. So, what will happen that increased perinatal morbidity and mortality will result. So, whenever the endothelial cells that are responsible for so many functions, they maintain the integrity of the structure, make it the proper organ of the body. So, when it is not functioning properly, we will see bleeding over there, we will see fibrosis, scarring, and so much more over there. So because of that, it is a very sensitive organ and is responsible and is basically a single sole connection between the maternal body and the fetal body. So when that connection is not balanced and it is disrupted, the morbidity and mortality, both of them, will be raised when we talk about the fetal life. Neurological impairments, the same is the reason for the neurological impairments over here as well. The brain requires the adequate amount of oxygen in order to grow properly, adequate amount of glucose and other compounds, other ions inside the body. But when it is not getting all of them adequately, the neurological impairments are usually seen in these type of children. The third one is the abnormalities of the fetal growth and development. These are basically they are associated with the hemorrhagic endovasculopathy. Okay, now talking about the pathology of the disease. Now, in this slide, we are looking at so many structures. The first thing that we will look at is the red blood cells or the fetal red blood cells. Now, these reddish appearing cells are the fetal red blood cells. Okay, the first thing. Now, the second thing is the fetal red blood cells and the ischemia that is moving from the lumen and is extending into the villous stroma of the placenta. These are the important points that have to be noted in the pathology of the hemorrhagic endovasculopathy. So this over here is the lumen, and this ischemia and these red blood cells are basically extending and moving into the stromal layer of the villi. This is the stromal layer of the villi, and they are slowly extending into it. If you can see these parts, they are slowly moving from the lumen into the stroma of the villi. So that basically means the process is progressing, the pathology is progressing and moving towards the more damage of the villi, from superficial to the internal structures and into the depth of the villi. Now the whole process is moving. Okay, now the next disease is the abruptio placentae. Abruptio placentae is basically a disease in which there is dispatching, or you can say disruption of the placenta, or it gets detached from the uterine wall. So that condition is known as abruptio placentae. What happens as a result of that? The placenta was not mature enough, it did not contracted enough to be removed from the uterine wall completely and safely. So as a result, there is hemorrhage. So a hematoma is usually formed because of the abruptio placentae, and hemorrhage can be so severe that it can be life-threatening for the maternal life. Okay, so internal bleeding, this is when now there are different positions of placenta. It depends upon where it attaches inside the uterus. So if it attaches on the upper surface of the uterus where mostly and normally it is present, it will cause internal bleeding in this area. But if the placenta was attached to the cervical wall over here in the most downward region from where the child was supposed to be delivered, but then where there this placenta was attached, this condition is also known as placenta previa. So the bleeding that will occur over here will be external bleeding, and placenta is separated from the uterus. In both these cases, this is the wall of placenta, that is the decidual wall, is being separated, and hence this bleeding is taking place over here. Okay, so now before discussing about the pathogenesis of the disease, we will be discussing about certain risk factors for the abruptio placentae. Now, the risk factors, most of them are related with the mother. For example, maternal smoking, cocaine usage, multiparity, more age or old age of the mother, hypertension that is induced by pregnancy, gestational diabetes, and so much more. All of these are considered to be the risk factors for the abruptio placentae. So now we will be discussing about the pathogenesis of the disease. Starting with the hemorrhage into the decidua basalis. Decidua basalis is the layer that is present between or separates the placenta from the uterine wall. So the hemorrhage basically takes place over there. Then there is decidua split, leading to development of the decidual hematoma. The blood clot that we have seen in the previous slide basically is present along the decidual basalis layer, and hence the hematoma over there that is formed is known as decidual hematoma. Then there is separation, and then finally compression, and then there is destruction of the placenta. So the whole process starts from the hemorrhage and ends up with the destruction of the placenta. Okay, now the morphology. Now this structure that is the basically the placenta is showing us these large blood clots over here, that is the hematoma. And this type of condition, this large hematomas, are usually seen in the case of clinical abruption. Clinical abruption is basically when there is rapid and destruction of the or dispatching of the placenta from the wall of the uterus, causing large amount of bleed and hence hematomas. And that is clinically important because it leads to pain, it leads to bleeding, it leads to maternal and fetal distress. That's why we call it clinical abruption. So this type of large hematomas are usually seen when we talk about abruptio placentae, and also when it is clinically important. Okay. Now coming towards the clinical features, there are so many clinical features of the abruptio placentae. We will be talking about them one by one. So the first one is the vaginal bleeding, that is more common when we talk about the placenta previa or placentas that are present in these positions instead of the upper position. Then we have uterine tenderness, abdominal or back pain, uterine tetanic contractions, fetal distress, that is very obvious. Maternal shock. Shock happens because of the hypovolemia. So the type of shock taking place over here is the hypovolemic shock. That is because of the large amount of blood has been lost because of this process taking place over here. Then we have hypofibrinogenemia, coagulopathy, and maternal and fetal death. So all of these are the clinical features when we talk about abruptio placentae. So the next disease that we will be talking about is the intervillous thrombi. Intervillous thrombi are caused by the rupturing of a chorionic blood vessel or a villous blood vessel inside the placenta, and because of that, what usually happens that the fetal blood gets in direct contact with the maternal blood. So conditions like blood group incompatibility can take place in the maternal body. So the complication will start from there. In this diagram over here, we are seeing an intervillous thrombus. Intervillous are basically the spaces where the maternal blood is being poured, and then villi are responsible for taking up the nutrients. So when the thrombi are present in that space, it means that some sort of blood leakage was present over there. So that forms intervillous thrombi or thrombosis in that area. Okay, talking about the pathology. Now, this is the area over here that is separating this fibrous and scarous area from the normal tissue of the villi inside the placenta. So, this basically is showing us the area of damage. This is showing us the area of scarring and fibrosis, and this is basically the normal area. This is basically the structure of a thrombi that is present in the intervillous space. Okay, on an ultrasound, whenever we are looking at a cavity or a structure that has been solid in its form, we will see structures like these. Now, this is basically the placenta, and this large portion inside of it is showing us a presence of a thrombi. So you can see it is not very difficult to diagnose these type of conditions over an ultrasound. So a simple ultrasound can show us that the placenta is going through an abnormality, and the progression of the disease and what are the outcomes can be speculated from there onwards. Okay, the next condition that we will be talking about is the placenta accreta. Now, placenta accreta is basically the area, or you can say the placement of the placenta inside the uterus where it gets attached. So, according to that, it has different types. The attachment of placenta also decides whether the child will be delivered normally through vaginal route or through a C-section, and also different complications of the pregnancy during and during delivery are also determined by the position of the placenta. So there are three different types of the placenta accreta. If we talk about the different positions of the placenta, we have placenta accreta. This is over here, and this is basically the area of damage present over here. Then we have PI. What PI stands for will be discussed in next slide, and this is the damage that is progressing into the uterine wall. This is more of superficial type, but when it starts to move and penetrate into the placental, into the uterine wall, it changes its name. And now PP. Look at here. It has disrupted all the uterine wall, and now it is moving outwards from here. So these are the three states of placenta accreta that we have seen over here. Okay, now the important part, the pathogenesis of the disease. Now there are different risk factors and the etiological factors for the placenta accreta. The first one is the surgery affecting uterus. Then we have Asherman syndrome, previous placenta previa, uterine radiation, uterine leiomyoma, and all of these collectively will cause disruption of the decidua basalis. Then placenta directly attaches to the myometrium when this decidua is not formed. Basically, it is the disease of this decidua. I have talked about before so many times that decidua is responsible for the or is a layer that separates the placenta from the uterine layer. They are not supposed to be attached directly to each other. Otherwise, the villi will directly penetrate themselves into the uterine muscles, and that is not normal. So, when in that condition, when the placenta will contract itself at the time of delivery and will be removed from that area, there will be a hemorrhagic state over there. It will not detach normally from there, it will lead to bleeding. So placenta directly attaches to the myometrium. Sensitiotrophoblasts penetrates through the decidua basalis and invades the myometrium. That leads to three conditions. The first one is placenta accreta that we have talked about. The second one is PI, if you remember from the previous slide, and that stands for placenta incerta. And the final one and the most dangerous and severe one is the placenta percurta. So this is all about the pathogenesis of the placenta incerta. Okay, now coming towards the pathology. Now these areas over here, if you can see these. Now this layer was supposed to be smooth and separating these structures from the myometrial wall and the uterine wall. But because of the disruption and not presence of the decidua over there, these cells that are the placental cells then are starting to invaginate and moving themselves and penetrating themselves into the myometrial cells. So the villi directly lies inside the uterine muscles instead of intervillous spaces. And same area you can see over here. Now the clinical features of placenta accreta. The first one is the third trimester bleeding. That is because of this area, that is the scarus area that causes the bleeding. Then we have hemorrhage because of the absence of decidua basalis. Then we have endometritis. And then finally we have disseminated intravascular coagulation, that is DIC. That takes place in the third trimester of the pregnancy as the complication of the process. So the next condition that we will be discussing is known as chronic uteroplacental malperfusion. So chronic means that the process is taking place over a long period of time and is causing the malperfusion of the uterus through the placenta. So chronic uteroplacental malperfusion will lead to the things that now we will be discussing are the complications of the disease. So the first one is the stillbirth. Then we have neonatal death and preterm birth, intrauterine growth restriction, and then finally neurological damage. All of these conditions are the result of the malperfusion. So perfusion through the placenta into the umbilical cord and then into the fetus. All of these processes are so important if the fetus has to survive these 9 months and then has to be delivered normally. So importance of perfusion, adequate perfusion can be seen very clearly over these slides. Okay, now there are so many etiologies of the chronic uteroplacental malperfusion. The first one is the villous hypoplasia. We will be looking at how the villous hypoplasia basically looks like in next slides. Then we have massive perivillous fibrin depositions. Also, how does this fibrin deposition and how does it deposit itself over there and how it appears under the microscope will also be seen in the lecture in the next slides. Then we have maternal floor infarction, placental infarcts, abnormally small or thin placentas, diabetes, that is the gestational diabetes, autoimmune diseases, fetal thrombotic vasculopathy. We have discussed about this disease in this lecture in the beginning. Then we have villitis, that is the infectious or non-infectious inflammation of the villi. Then we have chronic abruption, chorangioma. We will discuss about the chorangioma in detail in the later in this lecture. And then finally, the last etiological cause or the risk factor for the chronic uteroplacental malperfusion is the large remote intervillous thrombi, and that thrombi is basically blocking the exchange of the nutrients from the intervillous spaces. So all of these can be contributing towards the disease and can act as an etiological factor. Okay, now looking at the pathology. Now this slide is basically showing us the cross-sectional area from the placenta, and this is a vessel inside the placenta, and the lumen of the vessel is reduced because of the presence of the thrombi and other cells inside this vessel, leading to the malperfusion of the fetus and placenta. Okay, villous hypoplasia. Villous villi are basically the structures, we have talked about them hundreds of times, and hypoplasia means that they have shrunken in size. So this first microscopic view or the diagonal view of the villi are basically showing us that they have shrunken to the extent where the intervillous spaces has increased very pronouncedly. If you can see the areas between these villi, this is the intervillous spaces and it has increased pronouncedly, and you can see a conspicuous hypoplasia or shrinking of the villi over here. Now, this diagram is basically showing us the high magnification of the villi, and we can very clearly look at the shrinkage and the smaller size of the villi in this slide, and also some stromal debris over here can also be appreciated. So these two slides are basically showing us the hypoplasia of the villi and how the intervillous space has increased. Okay, now increased fibrin. Fibrin, when we talk about the placenta, the two types of fibrin are important. The first one is the Roher fibrin and the second one is the Netabuc fibrin. The Roher fibrin is the integral component, the necessary component for the basal part of the placenta, whereas Netabuc fibrin is present and is deposited in more deeper portions of the placenta. And the conditions like placenta accreta that we have discussed before in the lecture are because of the deficiency of this Netabuc fibrin, because it is responsible for the maintaining of the structural integrity of the placenta, and when it is not present in the normal quantity, in these areas, the conditions like placenta accreta can take place. Okay, now the placenta accreta, if the fibrin is reduced, conditions like that can happen. But if it is increased, the increased perivillous fibrin can be seen in the diagram over here. If you can see, this structure is much more wide and pronounced as compared to these villi. That is because of the more deposition of the fibrin over its surface, and the increased surface fibrin is causing the absorption ability of these villi to decrease. So that is a complication of the increased perivillous fibrin. Okay, now look at these slides. These areas over here, over the high magnification, you can see these whitish areas. They are basically showing the increased amount of fibrin over the villus, these areas. And cells of the villi are very small. They are like dots, if you can appreciate them. And this picture, it is basically a low magnification view of the cross section of the placenta, showing us the intervillous space that is highly covered with a huge amount of fibrin. All of this area, this light colored area, is covered with high amount of fibrin. Okay, so the next condition that we will talk about is the maternal floor infarction. Maternal floor infarction is not a true infarct, but morphologically it resembles with the massive perivillous fibrin deposition that we have talked in the previous slides. So this area over here, this whitish portion, is showing us the infarctive area, that is the maternal floor infarction, and the area where the infarction is present tends to detach itself from the uterine or the decidual wall. And you can also compare that it with this wall and this area, that how discontinuous it is. Okay, now coming towards the placental infarct. When we talk about placentas, we have normal placentas and abnormal. So this diagram is showing us the presence of a normal placenta. This is the infarction of placenta. This blackish area is showing us that this area is not being perfused with the adequate amount of oxygen. That's why it is infarcted over here and shrunken and disfigured placenta. If you compare this diagram with this one, you will see that the corners of this diagram, the placenta is disfigured and they are shrunken as compared to these areas. And also, if you can see these areas, they are usually edematous. That is because of the inflammatory process and other protective processes that takes place over there. So the area the villi basically becomes edematous. So they basically are showing the edematous areas in the placenta. Dead and non-functional placental tissue. And what are the consequences of this type of placental tissue on the infant? They are decrease of the blood flow to the heart. That is obvious because it is not carrying, the placenta is not carrying enough amount of blood that is been purified by the oxygen and nutrients in order to reach to the heart. And if the heart is not getting enough amount of oxygen, enough amount of blood, the first organ that is going to be damaged because of this process is the brain. Dysphagia and distress will take place, and as a result, there will be the neurological damage that we have talked about in previous so many slides. So decrease of the oxygen to the brain, and slowly, gradually, other systems of the body like kidneys and liver will also be involved and other outcomes will also be seen. Okay, now coming towards the pathology. If you can see this slide, we are looking at so many structures, but if you can appreciate this part, this is the area that is moving into the infarction. Wherever the color is dull, you cannot appreciate dark pink and red color in a slide and it is turning into white or blackish area. It is always showing the deficiency of oxygen in that part. So in this slide, we are looking at the deficiency of oxygen in this area, hence the infarcted part of the placenta or the villi spaces. Okay. Now the next phenomena that we will discuss is the chorangiosis. Chorangiosis basically is, or the word stands for the chorionic blood vessels. So when there is increase in the chorionic blood vessels, the process is known as chorangiosis. Now, chorangiosis itself uh, do not damage fetus or the placenta, but it shows the uteroplacental insufficiency and the distress through which through which the fetus is going through. So it is considered to be a marker of the disease that is going on. Normally, the chorionic blood vessels have 4 to 5 ends and 4 to 5 further divisions or stems. But when we talk about chorangiosis, they are divided into almost 30 to 40 extra vessels and that they are not required. But when the perfusion in the placenta is reduced, I compare it with the process of anastomosis that takes place inside the body. Whenever the blood supply has been cut off from any area, the surrounding blood vessels starts to develop some other routes to provide the blood deficient area with enough amount of blood. So they try to make another tree of blood vessels to reach that area. The same thing is happening over here. The perfusion is reduced because of any pathological process inside the placenta. So to compensate with that process, the chorangiosis has started because of the uteroplacental malformation, because of the distress of the fetus. As a result, it is basically a protective response that the body is causing inside the placenta. Now in this diagram, these small red portions are basically showing us the divisions of the chorionic blood vessels, and you can see their amount. They are abundant in amount. Okay, so here the last thing that we will be discussing is the uteroplacental malperfusion. Uteroplacental means that from uterus to placenta there is malperfusion, and we can see and we can say that the sensitiotrophoblasts, basically the cells, are dysfunctional over here, and they make or they show us the appearance of tiny Barker changes over here that are bulbous in structures and are responsible for reducing the lumens of the vessels, hence causing the malperfusion in the fetus. If you can appreciate these areas, these are supposed to be the lumen of the vessels, but they are filled with these tiny Barker changes or the sensitio-trophoblast that basically reduces the lumen of the vessel and hence causes the malperfusion or the uteroplacental malperfusion. So in this lecture, we have talked specifically about the vascular changes or the vascular abnormalities that takes place at the level of placenta and the umbilical cord, and how these changes causes malperfusion and leads to different complications like stillbirth, IUGR, SGA in the fetus. We have talked about their pathogenesis, their pathology, how they appear under microscope, and how we will differentiate one condition from the other, and what are the etiological factors. So this was all from this section. Thanks for watching sqadia.com.